On behalf of the Action Collaborative on Business Engagement in Building Healthy Communities, welcome to part 2 of how can for-profit businesses serve as anchors in their communities. For those of you who missed part 1, you can find a recording of that session on our website. A link will be in the Q&A or chat. I am Robert McClellan, an occupational and environmental medicine physician and professor emeritus at the Geisel School of Medicine at Dartmouth. Along with Meg Guerin Calvert, I serve as co-chair of the Action Collaborative. Our collaborative is an ad hoc convening mechanism under the auspices of the National Academies of Sciences, Engineering, and Medicine's Roundtable on Population Health Improvement. Our mission is to catalyze and facilitate private sector partnerships and actions of business, community, and public sectors to work together to enhance the lives of workers and communities by improving the nation's health and wealth. We have a vision of creating an active space where participants feel compelled to contribute to a transformational effort that makes powerful and measurable impact on business success, societal value, and improves population health. Our session today will be recorded and will be posted in a few days on our website. The presentations will run for approximately 30 minutes, leaving us plenty of time for discussion. Please put your questions, comments, and resources in the Q&A. I'd now like to turn it over to Megan Collado. Ms. Collado is a director of Academy Health, where she manages a number of Robert Wood Johnson Foundation grant-making programs. She will introduce our today's speakers and moderate the discussion period. Ms. Collado, over to you.
Thanks so much, Bob, and thanks to Alina and the Action Collaborative for convening us. I'm excited to continue the conversation we began earlier this month around the question of how can for-profit businesses serve as anchors in their communities. As Bob mentioned, I'm a director at Academy Health, and over the last several years, we've worked with the Robert Wood Johnson Foundation to manage a portfolio of research studies examining what it might look like for for-profit businesses to play an anchor role in their communities. As you may know, many nonprofit institutions like colleges, universities, hospitals, arts organizations, libraries, and others are often referred to as anchor institutions, as they have long been invested in their local communities' well-being and economic development. They are typically rooted in their localities by their mission, invested capital, and relationships with employees and vendors. Several years ago, the Robert Wood Johnson Foundation became interested in the open question of whether for-profit businesses could also serve in an anchor role. This webinar, and the one that preceded it on April 7th, are an opportunity to share findings from this portfolio of Robert Wood Johnson Foundation funded research that explored this question of how for-profit businesses might serve as anchors. In the April 7th webinar, 2 grantees shared findings demonstrating the wide distribution of anchor businesses across the country and discussed their strategies and motivations for investing in their communities, including things like focusing on a broader area of engagement, such as a metro area, and emphasizing investments in workforce and a strong pipeline of workers. In today's webinar, we'll dive deeper into 3 case examples of anchor businesses, including their influence on COVID-19 spread, their presence in rural areas, and a closer look at for-profit hospitals. I did want to note we're using the term anchor businesses as an exploratory term. There isn't a consensus on a definition, and there are different interpretations of this term emerging from this body of research. Really what we're talking about are anchor roles, approaches, and strategies. There will be time after the presentations for Q&A, so please feel free to put your questions in the Q&A box at any time. With that, I will turn to our first presenter, Megan McHugh, who's an associate professor in the Center for Health Services and Outcomes Research at Northwestern University's Feinberg School of Medicine. Megan?
Thank you, Megan, and good afternoon, everyone. I'm honored to be a part of this panel, and I appreciate the opportunity to talk to you about the work that my colleagues and I have been doing on anchor businesses. And this is a particular treat for me because earlier in my career, I worked at the National Academies, formerly the Institute of Medicine, as a senior program officer, and I have a very high regard for the work that the organization is doing. So I'm going to be brief today, but by the end of this talk, my hope is that you will be able to define anchor businesses, describe the characteristics of communities that have anchor businesses and those that do not, and then describe the ways in which anchor business policies may have contributed to community health outcomes during the pandemic. So first, there are, as you know, a lot of different definitions of anchor businesses out there. Our team has been using this definition for several years now, and it served our purpose as well. We define anchors as for-profit businesses that employ at least 1,000 workers in a small or medium-sized community, and we do exclude eds and meds. We use the 1,000 worker threshold as a proxy indicator that the business has been operating in the community for a while, that it's likely a large real estate holder, has sizable revenues, and is likely to be a self-insured employer responsible for the healthcare costs of their employees and family members. By limiting our definition to small and medium-sized communities, we expect that anchors are one of the largest employers in a community and likely dominate the economic activity of an area. So using data from the Census Bureau and Reference USA's business database, we identified about 2,600 anchor businesses in the United States. We found that they can be found in about a quarter of all small and medium-sized communities, suggesting that anchors could have a moderately broad reach as partners in community health improvement. So this table compares communities with and without an anchor business. Communities with anchor businesses were about as economically distressed as those without anchors, which was a little bit surprising to our team. We were expecting communities with anchors to be a little bit better off, although we know from a series of case studies and site visits that employees of anchor businesses often travel a long way to work and don't necessarily live in the same community in which they work. In terms of health measures, we found slightly higher rates of smoking, obesity, physical inactivity, and diagnosed diabetes in communities that had an anchor business. And so overall, our data suggests that there is considerable room for improvement in areas with anchor businesses. So one final point on this, and that is that most commonly, the anchor businesses were from the manufacturing and wholesale and retail trade industries. And from this, we concluded that associations that represent those industries, like the National Association of Manufacturers, might serve as key intermediaries in efforts to encourage anchor businesses to engage in community health improvement. So now shifting gears to COVID, for a minute, I want to take you back to the beginning of the pandemic in March and April 2020, when there were several high-profile news stories reporting widespread transmission of COVID-19 among workers in food manufacturing plants. This news is probably not surprising because many jobs at manufacturing plants require that on-site work. Employees typically work in close proximity with one another, and they often have long shifts, 8 to 12-hour shifts at a time. So as a result of this spread within certain plants, governors, county officials, business leaders had to make a really tough choice about whether to close businesses or not in order to help prevent the spread of the virus. And these decisions were really tough because it involved weighing the economic well-being of workers and communities with the risk of spreading the virus. But these decisions at the time were made with very little information about how the closure of the plants might affect the spread of the virus in the community. So you can see our objective here, which was to investigate the relationship between closure of large manufacturing plants and the daily county level COVID-19 rate in the early months of the pandemic. So we merged our anchor business data set with publicly available COVID data, and we reviewed news reports and called anchor businesses to get information on whether and when they closed during those first few months. And due to the intensity of this data collection effort, we limited our analysis to the southern region of the United States. So this red line in the figure in front of you shows the cumulative percent of counties that had a manufacturing anchor business that experienced a closure of that anchor during the time period. So you can see that during this time period, about 40% of the counties with an anchor business that was a manufacturer experienced a closure of a plant for at least one day. And the purple line shows the percent of counties with a manufacturing plant closure on any given day. So it peaks in April, as you can see, and then the line begins to fall in May when plants were reopening again. So we found that closure of manufacturing plants was associated with a significant decrease in the increasing trend of positive COVID-19 tests. You can see time zero and the vertical line here representing the start of a closure of an anchor business. After 40 days of closure, the daily incidence of positive COVID-19 tests was 1 per 100,000 population in the counties with a closure of a manufacturing plant, and 17 per 100,000 in a county that did not experience a closure. So the bottom line is that for a county with a population of about 100,000 individuals, closure of a large manufacturing plant was associated with 142 fewer COVID-19 cases over a 40-day period. And then finally, I want to share one more analysis that we conducted related to the pandemic. Anecdotally, we know that many anchor businesses were encouraging vaccination for their employees and for their families. Some launched education campaigns, some issued mandates, some were offering incentives for vaccination. They, of course, have an incentive to keep their employees healthy and at work. And because we know that anchor businesses have such a strong presence in their communities, we wanted to see if these efforts were making a difference. And so we conducted a study to investigate whether counties with an anchor business had higher COVID-19 vaccination rates than counties without an anchor. Again, using our anchor business database and publicly available vaccination data, we constructed several regression models, and we found that counties that had an anchor business had a vaccination rate that was about 2.3 percentage points higher than counties that did not have an anchor. We also found that the number of anchors made a difference. Counties that had more than one anchor had an even higher percentage of their vaccination rate. Nevertheless, the presence of an anchor was not the strongest predictor of vaccination rates. Political leanings of a county, the level of economic distress, the racial and ethnic profile of the community all had larger associations with the county vaccination rate. So in sum here, we found that almost a quarter of small and medium-sized communities have an anchor business, and they're well-positioned geographically to serve as partners in community health improvement. We also found that closure of large manufacturing plants was associated with fewer positive COVID-19 tests over a 40-day period. Even short-term closures, 2 and 3 days, seem to make a difference here. So we can conclude that the temporary closure of manufacturing plants might be a strategy that policymakers and business leaders could consider to slow the spread of the virus. However, we recommend that this strategy be adopted in combination with others like social distancing and mask wearing, because closure, obviously, of a manufacturing plant can slow the spread but can't completely contain it. And then finally, the presence of an anchor business is associated with higher vaccination rates at the county level, suggesting that the activities of anchor businesses to encourage vaccination may have been successful, and that anchor businesses may be well positioned to amplify public health messages. So I appreciate your attention. All of this work was completed as part of Northwestern's program on manufacturing and health. I'd like to thank the Robert Wood Johnson Foundation for their support of this work and Academy Health for their assistance with dissemination. I look forward to the conversation.
Thanks so much, Megan. Next, we'll be turning to Chris Katlitz, the National Senior Director of Health and Wellbeing at the American Heart Association. Chris?
Hi, Megan. Very good to be here today. Let me just share my screen. So I'm looking forward to sharing with you the results from our research on perceptions of anchor businesses in a rural West Texas community. Sorry, my slides are not advancing. Try it again. Let's try one more time. I might have to advance my slides like this. I'm sorry, folks. So first of all, I want to thank the Robert Wood Johnson Foundation and Academy Health, and I have no potential conflicts of interest to disclose. So Megan Collado spoke about the anchor institution literature, and so I won't recap that except to say that less is known about for-profit organizations, and even less, there's even less in the literature about whether low-income and rural communities can have effective anchor institutions, whether they are nonprofits or for-profits. So this is a case study of Midland and Odessa in Texas, and we wanted to explore the perceptions and support for the anchor business concept in the general population. We also wanted to understand the motivations and barriers for for-profits to be anchor institutions in this rural community. And finally, as Megan said, the term anchor business is an exploratory term, and so we wanted to test the salience and acceptability of the terms anchor business, social determinants of health, and health equity with key business representatives. We adopted a mixed methods approach. There was a general population survey that was conducted by Harris, 500 residents in the Midland-Odessa region. And then we conducted structured interviews with local representatives from both the for-profit and nonprofit sectors on the motivations, perceptions, barriers, and opportunities for anchor businesses. So before I dive into the results, I just quickly wanted to paint a picture of these two towns. They are located very close to each other in West Texas. As you can see, their combined population is quite low, about 185,000 residents. These towns originated as railroad towns. They then evolved into cattle shipping and regional financial hubs. And today they are the epicenter of the Permian Basin oil and gas boom, but this boom is also susceptible to periodic busts. And the energy and mining sector is the predominant employer in the area, employing about 30% of the workforce. When we look at key socioeconomic indicators, despite the fact that they are located very close to each other, there are some differences between Midland and Odessa. Odessa has fewer residents that have a bachelor's degree, and the median household income is also lower, but they have similar median gross rents. And then we look at the county health rankings. It's a bit of a mixed picture, and I'll have you can read these statistics. I wanted to highlight the fact that Midland has more mental health providers compared to Odessa, higher high school educational attainment, and also lower childhood poverty. And so I just thought that would be interesting to show you a snapshot of these two towns. As far as our general population survey was concerned, when we asked people about whether for-profits or non-profits had a very large or large amount of responsibility to address social determinants of health, you can see that less than 50% of people said that these organizations have a very large amount of responsibility. However, we did look at different nonprofit types of nonprofits and also different types of for-profit sectors. And so you can see that when you kind of dive a little bit deeper and look at that question at a more granular level, there is higher levels of agreement on whether these institutions should improve social determinants of health. We looked at specific social determinants of health, and you can see, again, that there is relatively low level of agreement on whether for-profits should address these different aspects of social determinants of health, with access to healthcare sort of being the highest one, although there's a cluster of those in the 40%, but nothing above 50%. When we looked at specific industry sectors, sorry, not sections, industry sectors, the only social determinants of health that had more than 50% of respondents saying that they should address these was job training in the oil and gas and technology sectors and safe roads in the oil and gas industry. And that is not surprising given the impact that the oil and gas industry has on this community. Our interview sample, we interviewed 4 non-for-profit organizations and 5 non-profit organizations. They were mainly in the for-profit sector. The leaders were CEOs or owners. You can see the list of the various types of businesses listed there. And the non-profit interviewees were either executive directors or directors, and you can see the types of nonprofits, and our sample was slightly more male than female. So when we look at the qualitative results in terms of themes, there were 4 themes that sort of rose to the top: organizational motivations, barriers and benefits, the different types of approaches to partnerships, and then the appeal of the nomenclature that we have here, and also proposed alternatives to the terms anchor business, social determinants of health, and health equity. As far as organizational motivations were concerned, among the nonprofit organizations, there was strong support for for-profits to have a responsibility and indeed an obligation to improve the economic health of the region. And reasons for doing this range from it being the right thing to do, it's strengthening the company's economic stability, and then also the mutual benefit between the company and the local community. And the key social factors that our for-profit respondents highlighted were housing, education, healthcare access, the physical environment, and also employment. And again, there are reasons for these social determinants of health rising to the top based on the nature of the mining and oil and gas extraction business in this community. As far as our nonprofit respondents were concerned, unsurprisingly, all of them believe that for-profit organizations have a large amount of responsibility to make improvements in the local community. They felt that for-profit organizations should invest more. They also believed or expressed the view that their organizations, the nonprofits, could act as the planning arm for for-profits. And finally, the nonprofit respondents believe that government agencies should play a greater role in coordinating multi-sectoral collaborations. Very importantly, what are the barriers and also the perceived benefits for-profit organizations operating as anchor businesses? The barriers that were noted amongst our for-profit respondents were economic volatility, which creates the conditions for there either to be a boom or a bust in this local community, limited staff capacity and time to engage in health equity initiatives. And also, interestingly, they noted that there is indifference by transient workers to be engaged in their community. Benefits included creating a culture of altruism, enhancing the image of their companies in the local community, and also having a positive effect on employee engagement and retention, which was noted in our first webinar. The nonprofits spoke about the economic downturns that lead to less investment, and they also highlighted some negative perceptions of the oil and gas sector in this area, especially as it relates to the environmental impact. Many similar benefits were noted. I would just add that they included the fact that for-profits could have tax write-offs for their philanthropic activities in the area. When we looked at approaches to partnerships, the for-profit respondents noted that nonprofits follow the rules, and this slows things down in partnerships, that they felt they were more nimble and agile to get things done. They also noted that there often disagreements can arise about the amount of marketing and advertising spend that various partners want relative to the overall community investment, and this can lead to disagreement. But they did believe that their organizations bring expertise, capacity, influence, and networks to the table. Among the nonprofit respondents, some of the issues that were raised was lack of clarity about who the decision maker is and how essential that is to partnership. The fact that often parties bring different priorities to the table, and this can lead to tension. The challenge of working with a local business that has a non-local headquarters, that's particularly true of the oil and gas industry, because many of the headquarters of the large oil and gas businesses are in Houston and not in Midland and Odessa. And then finally, they spoke about the generosity of nonprofits, their joint commitment to position Midland, Odessa as a community of choice. So when we looked at how acceptable the term anchor business was, it was generally interpreted positively. One respondent linked the term to anchor babies, which has a negative and racially charged connotation in the area. And none of the respondents felt that they could improve on the term anchor business. It was generally acceptable. When we looked at social determinants of health and health equity, again, both of the terms were generally received positively because they sound holistic, and health equity was perceived as relating to opportunity. Some noted that the positivity of the terms depend on the audience and how they are framed, and many felt that further explanation was needed to make these terms more understandable to the general public. And then some of the alternatives that were offered were health opportunity, access, equal access to healthcare, and culture barriers to healthcare. I just wanted to highlight that there is a large for-profit coalition operating in this area called the Permian Strategic Partnership, or PSP. PSP was 21 member companies prior to the COVID-19 pandemic. The pandemic led to mergers, acquisitions, and many companies, several companies closing their business. So they now 17 for-profit oil and gas companies who formed a separate 501c3 nonprofit organization to invest in the Permian Basin. And you can see the mission there. And between 2019 and 2020, the PSP made an investment of almost $50 million in this area and leveraged much more in terms of collaborative investments. And if you look at their website, the way in which they have framed their investment is it's very much the right thing for them to do. A couple of limitations to note. Obviously, the pandemic period was very volatile on businesses and also gas prices. There's also non-response bias. We did not do a detailed analysis of all firms in Midland and Odessa, which was outside of our scope. And then the role of out-of-town oil and gas firms was not investigated, but this may play a role in community investment. In terms of the discussion and implications, so we saw relatively low levels of support for for-profit businesses having a very large amount of responsibility to address health equity. There was strong support among for-profit businesses that they should promote the economic health more broadly in their communities, and this was seen as the right thing to do. Local nonprofits believe that for-profits should invest more in health equity projects. Some of the key barriers are economic volatility, low staff capacity, and the perceived indifference of a transient workforce. And then finally, terms like anchor businesses are generally acceptable but they could have a political resonance in more conservative towns. And then finally, the impact of for-profit business coalitions like PSP need to be studied further. So thank you very much.
Thanks so much, Chris. Next, we will be turning to Corey Cronin, an associate professor in the Department of Social and Public Health at Ohio University, and Berkeley Franz, a associate professor of community-based health also at Ohio University.
Thanks, Megan, and hello, everyone. Really happy to be a part of this conversation. As Megan said, my name is Corey Cronin. I'm also joined with Berkeley Franz on this study, and we'll be handing it back and forth a little bit. But in our part of this conversation today, we're really industry focused, that we are interested in for-profit hospitals specifically. And with the time we have to allow plenty of time for questions and discussion at the end of this that I'm looking forward to, we've taken the approach of giving kind of a high-level overview to the entire study and some of the lessons we've learned in doing this work. And so to get started, I want to both recognize our study team who has been working on this, and it's been mentioned during challenging times. We've certainly had to pivot a little bit given the nature of the pandemic and talking to healthcare organizations that had plenty of things going on during this time. And then also thank the Robert Wood Johnson Foundation and Academy Health. And so to get us started, I really want to talk about, we've seen the definition of anchor institutions, and it's already been mentioned that medical institutions are often automatically included in this. And so we did want to focus in on for-profit hospitals specifically. And there's some interesting things there in that the nonprofit counterpoints here have some regulations in place that compel them to do things that we would consider anchor activities. So whether that's doing community health needs assessments every 3 years or submitting different activities they do for their community to the IRS for their 501c3 status. On the nonprofit side, hospitals are large, stable, often employers in their community. They are also directly about health, which has a lot to do with this conversation about anchor organizations and anchor activities. And we do know from the literature, though, that for-profit hospitals, to a lesser degree, do also participate in these types of activities and do these types of things, even though the regulations don't exist the same for them. And that was really the objective of the study, was to learn more about that. We took an approach of using both national data sets to look across the country at some trends, and then also to do a case study approach to get more detailed data within selected communities based on their characteristics. And I'll hand it over to Berkeley to talk a little bit more about that.
Thanks, Corey. So we call our study the Ohio Anchoring Health Study. We have a website we encourage you to visit if you're interested in learning more about the study, called anchoringhealth.org. And we were broadly interested in what Corey said, just trying to understand how can we measure the anchor activities of for-profit hospitals if they're not formally required to publish reports every 3 years like nonprofit hospitals are. So we're trying to find alternative ways to determine what these activities are and also motivations for doing these activities. So we do this in 3 different ways. So we explore national data sets to see where for-profit hospitals are located, to understand their potential impact on community health if they were to kind of embrace this anchor identity. We also engaged hospital leadership to talk a little bit about why they may undertake anchor activities, any challenges they may face, or if they kind of adopt unique approaches when doing so. And then we also talked to local residents around for-profit hospitals to understand what expectations exist for hospitals to participate in this type of work, or just how knowledgeable residents are about hospitals and their particular interests in this type of activity.
So to begin with, we're going to talk about that, look at the national landscape. And so to start, for-profit hospitals are a minority of the hospitals in the United States. They're about 20% of general community hospitals that exist, though through hospital mergers, acquisitions, the consolidation of healthcare markets, it is a growing area, which we think makes this a timely topic, a topic worth considering. We certainly spoke with some hospitals, some community members, where the hospital was for many years nonprofit within the community. and had switched its ownership status with some of that consolidation to for-profit, and got to really hit on themes of what the meaning of that was, or how that did or didn't change the way leadership thought about or approached things. And if you look at the map here, we can also see that for-profit hospitals are more likely to be in some communities than others. And there are a number of reasons for this that we looked into. There are some very practical policy reasons why hospitals are not in some parts of the country. There are states with policies that are more favorable to for-profit hospitals' operations and the way that they tend to do business. Things like certificate of need laws, for example, come into play in where hospitals are located. But you can see here, again, throughout the country where for-profit hospitals are more densely located. This map was also really influential to us in creating our case study approach. We really wanted to take an approach where we maybe don't have a representative sample nationally, but we do have a diverse sample of healthcare markets. So we were very interested in finding some markets where, for example, it is only a for-profit hospital that serves a 35-mile radius of people versus other markets that are maybe more urban and balanced, where you have an equal number of for-profit and nonprofit large health systems operating. We thought some of those characteristics could provide way in detail and explanation. And so one of our first questions was, what is even the opportunity for, or the potential for-profit hospitals to take on these anchor activities, this role in a community? And we do find that on average, the counties that for-profit hospitals are in operation in have higher needs, not unlike the previous two studies we've seen. In fact, that there is a greater proportion of the population uninsured or reporting poor health outcomes. And so what we frame this around is that there is an opportunity for this type of identity activities, concentrated, focused efforts by these organizations if they were to take on this role. One element that we could look at, again, nationally and quantitatively with data of the for-profit hospitals is their role as an employer. One part of the anchor definition is stable employment, economic activity within a community. And we do see maybe a tension here when we looked at this between some of the characteristics of for-profit hospitals, some of their pressures in the way that they do businesses, that we do see on average, they employ fewer people for similar sized organizations, and they pay overall less in salaries and benefits than the other hospital ownership types that we see. And we can also calculate that on average, they pay people less. And so while still large employers and having a lot of jobs in the community, services and supplies purchased, in this one comparison to other hospital types, we do see some differences.
Okay, so we also looked at individual hospitals and we constructed 10 case studies. And like Corey mentioned, there's a diverse set of case studies based on regional location and size and the healthcare market that they were a part of. And so these case studies we put on our website describing these different hospitals, the communities they serve, and the particular anchor activities that they adopt in each of these communities. So here's an example of a de-identified hospital community case that we included. So we have some broad themes from talking with leaders within these hospitals. And we found some interesting things that hospital leaders weren't necessarily familiar with anchor language, but when we described that to them, they immediately kind of agreed and said, oh yeah, that's what we do. So there was this kind of general agreement about social responsibility and community responsibility that was shared among for-profit leaders, even if the language of anchor wasn't always familiar. Leaders were also able to speak on anchor activities and how they kind of benefited their organization. I thought they were almost common sense in a way in terms of connecting with communities, connecting with potential future patients, but also in their role as a healthcare provider, just feeling like they had this general responsibility to respond to not only the needs of people who were paying for services, but people who just resided nearby potentially. So, leaders also, though, reported feeling left out of community conversations and feeling like they weren't always brought to the table when other hospitals in the community were kind of gathered to address specific community health issues. And so because they're for-profit status, they felt like they sometimes had a kind of a negative reputation in the community, or they were assumed to not be interested in this type of work. And they also, leaders talked about how they felt like their tax contributions were underappreciated, given that nonprofit hospitals are largely tax exempt and do not contribute to the community through tax paying mechanisms. So here's just a couple of interesting themes that we found related to these hospital leaders and their description of how they undertake anchor activities. And so we had, a very clear and persuasive answers in terms of why being an anchor institution was considered a priority, in terms of their own employees, but also people who lived in the surrounding community. And then we also heard from hospital leaders that they sometimes employed kind of unique and strategic approaches to being anchor institutions. So they felt like because they were a business, they didn't have the same opportunities to just do work purely because it was charitable. And so in response to that, for-profit hospital leaders talked about needing to see a return on investment of any kind of anchor activities, or make sure that they could make the business case for it when talking to hospital leadership. And so we found they often kind of adopt unique ways of being anchor institutions, but these leaders felt very strongly that they still met the criteria of being an anchor institution.
And the last arm of our study, much like Chris's, was a community survey. So we used Qualtrics, the company, to survey the population of the 11 case study sites that we have. We had a sample of 522 participants, and the findings were somewhat surprising to us. Not surprising overall when asked questions about the differences between public, nonprofit, and for-profit hospitals. This is an area that the community is not greatly aware of, or understanding the difference, appreciating differences when it comes to different regulations or things that organizations have to do by these different ownership types. What was a little surprising to us is, for example, in open-ended responses, when asked about things that hospitals should be encouraged to do or do more of, almost universally, the focus in analyzing those text answers were focused on things like cost and quality, not a lot on things we might consider anchor activities, community engagement, health improvement opportunities. When asking in closed-ended questions about what priorities or what elements of hospitals rank highest in importance to people, they again were focused on things like the reputation, cleanliness of the hospital, other things having to do with convenience, like the distance to get to the hospital. And so overall, our conclusion is, from a community perspective, the level of the hospital's community engagement is of lower stakes than some of these traditional, long-lasting issues we see brought up in healthcare of cost, access, and quality. And with that, we want to thank you all again today for having us as part of the conversation, and turn it back over to Megan for the discussion portion.
Thanks so much, Corey and Berkeley. So now I've seen a few questions come into the Q&A, but if others have questions, please feel free to put them in. I also have a few as well. I will, I'll note one question in here. A questioner mentioned, have you ever considered backbone business rather than anchor, which I think is an interesting term and might resonate or be more readily understandable than the sort of anchor or business concept. So that's a helpful question and suggestion. I had seen a question come in earlier, I think for you, Megan. I'm not sure if it got addressed live or not, but the question was whether you had any information on whether anchor businesses had vaccination policies. Were you able to gather any of that information?
I wrote a little bit in the chat, but essentially I'm not aware of anyone who has compiled that information other than trade associations. So I know that several associations have polled their members to see how they are handling, different vaccine policies and other protective policies during the pandemic. So they might be the best source of information on this. Right now, we're doing a series of case studies in relatively low vaccinated areas. And we're having conversations with the anchor businesses there. And for the most part, they're taking some protective measures, but we haven't spoken to a single one that has mandated the vaccine.
Another question is, other than looking at COVID, did any of your studies look at for-profit anchor businesses and their impact on social determinants of health or other specific health outcomes? Were there any other outcomes your studies examined beyond COVID?
We have, I mean, in sort of another arm of our work, we have looked at how the social determinants of health have affected the work that goes on in large businesses. And so what we determined was, what is probably not surprising to you, that employees who come from communities and neighborhoods with high levels of poverty, low levels of education, have higher rates of absenteeism and tardiness.
And another question in the Q&A was whether you saw any major anchors that have an impact on community cancer outcomes. Did any of your studies look closely at cancer outcomes? Unfortunately, no information.
No, I can, I will say that hospitals generally, for-profit hospitals included, I know Chris mentioned partnership some, and that is an area that I think is worth greater investigation with hospitals. And so an interesting thing is we, and I think others, were looking at activities, not necessarily measurable outcomes, just in trying to get in this exploratory way a sense of the landscape. But hospitals do often fundraise for cancer associations. I think that's really common. So it's an area that I could see potential for, of course, with hospitals.
Another question is, are there specific metrics or measures that you see the anchor businesses you've studied using to track either actions or interventions or outcomes impact return? Any kind of specific metrics or measures coming up across your studies that you've seen?
I would say that's a question that was very much of interest to Corey and I, because hospitals, for-profit hospitals, are not required to formally measure the impact of the work or even report that they are doing this work. And when we talked to hospital leaders, they felt it was very important that they have the kind of individual flexibility to decide what they disclose and what they report to the public. And that was really much of interest. They were very concerned about having any kind of required metrics or measures imposed on them as a part of any kind of policy change. Yeah, putting that out there just in terms of there may be some kind of pushback into some proposed changes in how we measure these types of activities.
From our perspective, you know, what we noticed is that companies were more focused on traditional economic indicators rather than health equity indicators. So looking at job training, employment, retention of employees, and those types of metrics. So this is somewhat anecdotal and worth sort of investigating further, but I do think that the degree to which for-profit businesses have leaders in their organization that are familiar with social determinants of health and health equity is the degree to which they include those metrics in their strategic planning and in their outcomes reporting.
And I'll just add, so we work with a lot of large manufacturers, and measurement and outcomes is sort of at the heart of what they do. They measure everything. They know the price of everything, even the stuff they throw out. They know, they know all about. But the one thing we found that was really vexing to them is to, measure the impact that they were having on their communities. And so it was sort of a lot of more rudimentary measurements, surveys, focus groups, of people who may have been touched by some of the activities that they were engaged in within the community.
Another question that's come in, interested in any of your thoughts on how can community and public health nurses or workers get involved in anchor partnerships or other programs with anchors? Any thoughts on that question?
Sorry, Megan.
Sorry, I'll try to be brief. So I will say that I've noticed a change. You know, when we had conducted a study, several studies a few years ago, we were looking at the extent to which anchor businesses were engaged with local public health leaders, and there wasn't a whole lot of engagement, even when companies were specifically looking to engage in community health improvement activities. It just didn't occur to them to reach out to a lot of the local health department. With COVID, we're seeing a little bit of a change there in terms of local health departments actually reaching out to the companies and the companies doing the same, asking, you know, for possibly vaccine clinics to be set up in their offices or asking for educational materials that they might have on hand. So I feel like just in the work that we've been doing the past couple of years, we're seeing more engagement and a more willingness from anchor businesses to have folks from the outside come in and rely on that outside expertise.
Yeah, I'll share from the hospital side also. I know we heard at least once, even an expression of some frustration of not feeling invited to the table in community discussions around health, or at times when data was being shared. And I think a lot of this comes into the different regulation by ownership type. There are some, within policy, some policies that really reinforce the idea that nonprofit hospitals and their local health departments would work closely together on certain things. And so when that's required, that's an obvious partnership or even a mandated partnership going in two directions sometimes. And like I said, we did hear from at least one leader of a health system that they feel like they aren't invited to the table, even though they have a role, want a role in community health and those conversations.
Another question asks, did any of your anchor businesses view less absenteeism and turnover through their community engagement return on investment for the business? Did any of you look at absenteeism or turnover?
We didn't specifically look at it, but it came up in our stakeholder interviews where there seemed to be a general acceptance of the hypothesis that acting as an anchor business and addressing social determinants of health was a good workforce attraction and retention strategy. Not convinced that that's supported by strong empirical evidence, but there certainly seems to be this general acceptance amongst for-profit business leaders that this is good for their workforce.
We did not look at that specifically, but we did ask some of the hospital leaders about how things had changed as a result of the COVID-19 pandemic in terms of their anchor activities. And one of the things it did say is that it really encouraged them to turn inward and focused on their workforce and employee health and well-being. And that was interesting. They thought the pandemic in particular kind of limited some opportunities for community engagement, but also kind of reinforced the need to focus on employee well-being and also equity in terms of their workforce.
Another question and sort of follow up to the comment that it helps to have leadership who are familiar with social determinants of health. And this is probably for you, Corey, and Berkeley. Did you notice a difference in the professional background of hospital leadership comparing nonprofit and for-profit hospitals, such as, you know, background in business or public health? Were you able to look at that?
Yeah, and the interesting thing, the most interesting part of that to me was how fluid people's careers are between the two, and that they do recognize differences, but overall, I would say there was confusion. Confusion's the wrong word. People wouldn't understand why you would necessarily act differently depending on which ownership status you had as an organization. We did have one example, I know, where the person we were talking to really attributed what they thought for a for-profit hospital to be a greater amount of community orientation. They attributed it to leadership, that there was someone in their leader with this great background in doing this work for another organization. And so when they started leading this organization, they just really put those things in place. We had the opportunity to talk to some people at a health system level, so like a corporate office of many hospitals rather than a hospital in a community. And they too, most mentioned backgrounds in different ownership types over their career. So they're not linear careers in only for-profit. I don't think we discovered that, at least, that anyone had a linear career in only a for-profit hospital. It seems that people move fluidly between the two. The only thing that came up anyway in maybe detracting was, and Berkeley mentioned this in one of the quotes, needing an explanation to something like shareholders of how you're spending the resources of the organization. And so if something is an anchor activity, there's a time to, again, at least according to some, a time to at least present how that is a good use of the corporation's money, and needing to think about it that way. But it didn't seem like they actually changed the perspective or the way they thought of things because they were working for a for-profit hospital.
And I would just add that I think this is similar with nonprofit and for-profit hospitals, that leaders with a public health background or with, knowledge of social determinants of health do a really good job of translating what the impact of those types of activities are, both in terms of the business model, but also on, community or population health. And that it seems like when there were really strong leaders, the kind of culture of the hospital was more accepting, of SDOH work or equity focused work. And that was really similar with for-profits as we've also found with nonprofits.
I know we're into our final minutes here, but I thought maybe each of you could just quickly identify, one theme you believe should be studied in the future or an aspect of your research you hope to build on. Megan, maybe we'll start with you.
I mean, the more evidence, the better. And that's ultimately what we want to do. Like, we want to be able to show companies that there is a value to contributing in their communities.
And Chris?
So when I think about the lack of capacity to address health equity, especially in low income and rural communities, and the role of the CEO and senior leaders in perhaps smaller organizations, one idea that comes to mind is, looking at how training CEOs in these and other C-suite leaders in these concepts and the importance of investing in community health, whether that would have an impact on their ability to see themselves as anchor institutions and act in that way.
Corey in Berkeley?
I would just say quickly that, it seems like from all of the studies presented today, there's a lot of opportunity for for-profit businesses to make an impact in the communities in which they're located, especially in terms of economic and in terms of health outcomes. And so finding ways to kind of encourage these organizations to do this and to understand why they may want to do this, it may be different than why nonprofits engage these type of activities, seems like a really critical next step.
Yeah, and I'll only add, I agree with that. I'll only add that one of the things with hospitals that I started with saying is their activities being about health often let them into a definition like this, but that also means that a lot of things are maybe passive and not active. And so dialogues and intentionality, even if it's something about employment policies, how you hire, I think those conversations could increase.
Well, thanks everyone. I really want to thank each of our panelists for your remarks and the Action Collaborative for convening us. I know we are at time, but I think this has been a great continuation of the conversation around the role for-profit businesses can play as potentially anchors in their community. We again heard from Megan that a quarter of small and medium communities have an anchor business, a lot of potential for impact, as Berkeley mentioned, and we encourage any of you to reach out to us with questions if you're interested in learning more about this work. Thanks again.